A lot of times we'll do more of a general talk, but tonight we're going to get real specific about the back. Talk a little about why people have back pain, the pain generators, treatment options that we have. So should be pretty fun. It'll be interactive. We'll ask questions at the end too. So we're going to have talking in the end quite a bit and kind of go through some questions. So we'll be spending about an hour together tonight, kind of going through these types of things. Has anybody anybody new to Reju? I see a few new faces. Raise your hand if you're new. Been around, been here before, raise your hand. So lots of old friends, which is cool. So we'll kind of go back. I mean, a lot of you who've been here before, you've probably heard my story, so I'll just kind of fly through it. But kind of grew up, military kid, eventually made it to high school. It was pretty cool. Played a lot of tennis. You and I looked a lot the same in high school. We both had the mullet. You still have it. I wish I did. And then now eventually got my hair cut, and this is where I am today, or a couple years ago. But the transition kind of taught me a lot. From this mullet stage where I'm at now, I really learned a lot about myself. After high school, this is my senior tennis career. Graduated high school, went to school at UND in Grand Forks, and I was an art major. So I studied art for 4 years. The second year into college, I needed to get a summer job. My dad told me I had to make some money and pay for myself. So I got a job in a nursing home. Anybody ever worked in a nursing home? It's incredibly humbling. It's incredibly amazing. But I learned a lot about myself that summer because I was a CNA, so a certified nurse's assistant, and I worked basically with elderly who had strokes and couldn't really take care of themselves. And there's a gal, her name was Barb, and she had a stroke, and I was assigned to her the entire summer. So if you've been in a nursing home with people that had strokes, she couldn't take care of herself. She couldn't talk. She would scratch her face. Had gloves on, so I'd feed her, I'd talk to her, I'd put her to bed. But it was really an amazing summer because as I started spending time with Barb, I realized a lot about myself, that I was destined to help people. I just had a heart for people. I fell in love with Barb. And by the end of the summer, though, fast forward 3 months, Barb had her gloves off and she was feeding herself and we could talk. And it ended up that Barb was just depressed. She had nobody to talk to her. And 6 months or 3 months later, what was a disability from her stroke was a lot of it was just overlapping depression and just feeling lousy. So I felt like, man, if I can infuse love into someone, there's a lot of good I can do for people. So I kept my major as a visual arts major, but I thought I'm going to go pre-med because I thought medicine is the best way to treat people and to help the world, right? So I did 4 years of undergrad in arts and pre-med, so took all the sciences, had to be very competitive, had to keep my grades good to prove I could do it. After 4 years, applied to med school. Luckily, I got in. Told my dad, I got in, I'm going to med school, which is exciting. So I spent 4 more years then studying medicine, studying disease, studying breakdown in our bodies and everything there. At the end of 4 years, as a medical student, you have to make a decision. What do you want to do for the rest of your life? And I thought, gosh, I want to treat as many people as possible, from kids to adults. So I went into a 3-year residency program in primary care, which means I was going to be able to treat everything, from hypertension to strokes and help people. And that was a 3-year program. Towards the end of my 3 years, I was realizing, oh my gosh, I'm just writing prescriptions. I'm seeing 30 patients a day. This is not very fulfilling. It was actually not even that mentally gratifying. I was just writing prescriptions. Next when that hurts, here's antidepressants, pain medications. And it was unfulfilling still. So I was like, oh no, I'm 12 years into this, and I don't think this is not made for me. So I went back again, and I did a fellowship in sports medicine and non-surgical orthopedics, and just dove into the body, anatomy, physiology, how the body works, pain, orthopedics, and all those things, and fell in love with it. I was like, this is where I was meant to be. This is who I was meant to do, and I'm going to help a zillion people with the skills I was learning. So graduated from that process probably about, must be 22 years ago or so, and from then it just how things happen. Your life, just meet people and things happen, and so from there I've dedicated everything I do into figuring out how to really treat people the optimal way, to not just cover things up with medications. How do we avoid surgery, and how can we really repair the body? So all of this talk here is 25 years of passion, writing 8 or 9 books, and putting all this information together and developing things for people. But we really think that Reju Medical kind of represents the standard of care on a national scale. We do about 3 or 4 conferences a year. We have doctors flying from all over the world. We're going to be hosting one here in about 6 weeks where doctors will come all over the place. We'll teach them things, teach them skills, and they're looking to us as that new model of healthcare. So it keeps us sharp because we always have to be learning, cutting edge, looking at the evidence, and doing what's right for people. But as far as my clinic goes, you guys came in, it's kind of broken down into 3 different tiers here. We have the orthopedics, which is chronic pain, sports medicine, regenerative medicine, surgery, all those different things are underneath that umbrella. We do a lot of what's called functional medicine. Has anybody heard of functional medicine? So functional medicine is like, yeah, you've heard of it. It's like, what can we do to maximize the outcomes of our body? So it's a lot of lab analysis looking at our hormones, testosterone, progesterone, what's happening with our adrenal glands, our gut health, our inflammation in our body. Because patients come to see me all the time with chronic pain. They're inflamed, they're stressed, they're fatigued, and I can help them. But when their body's in such an inflammatory state, we have to set that right with functional medicine. The other thing that helps that too is what's called lifestyle medicine. It's treating people how to eat healthy, nutrition, how to just live life healthily, because that's super important for our chronic pain management. So we come now to the spine, just kind of talking more specifically about spine, chronic pain. It's really very common. About 8% of adults are going to experience some kind of a low back pain or spine pain in their lives, and some of it can be pretty debilitating, bringing them out of work, out of social activities, and kind of isolating us. It's the leading cause of disability in adults less than 45. So it takes them out of work, unemployment, and those types of things, because it can be devastating when your life is made on being active and strong, and now you can't use your back. It takes you out of your career. And it's an economic burden, and we're all complaining about who hates their premiums, their copays, all that stuff is way too expensive, right? When you look at the economic cost of low back pain only is $300 billion to our economics. If you look at the average cost of a spinal fusion, it's about $80,000 to $150,000 for a spinal fusion. So we understand, okay, one spinal fusion, all of our premiums are going up because it's so expensive for the hardware, the cost, the hospital stays, and all those things are as well. And then clinically, 20 years ago when I first started doing these things, I did not like back pain patients. Not because I didn't want to help them, but I didn't have the toolbox to fix their problem. It was like, I don't know, here's some pain medications, let's try some cortisone shots. You're still having pain, okay, just go to the surgeon because I don't know what to do with you and I can't help you anymore. And so thank goodness I have really studied, and thank goodness now I know how complex the low back pain is. I'm going to go over some stuff today on how complex it is and why we have to look into things. But now we can treat this. And I love, one of my favorite patients when I see chief complaint low back pain or chief complaint headaches and neck pain, because I know what to do with those and I can get those patients better. It's exciting. So our goals of today is to understand why the spine breaks down. What's the degenerative process? Why does the spine break down? Number two, what are the pain generators? When somebody comes in to see me, I tell them I can help fix your pain, but I've got to figure out what's causing your pain. And that's why 20 years ago the low back was so hard, because it was like this black box in my mind. There's so many things that can cause pain. It's so hard to diagnose. It's so hard to treat because there's so many pain generators. And to tell you the truth, it's usually not just one thing causing your pain. It's not just the disc. It's not just the facets. It's a combination of pain generators that make your back pain very unique. So, and then we'll go over a little bit of the treatment options as well. All right, so back to school. We're going to go over kind of anatomy, the low back. It's going to be fun because you can relate to it if you have back pain. But it's going to start kind of showing you guys, oh, that's what's causing my pain. So, do you need Germans in the house? No, I just saw my German friends come in. So, oh my gosh, we're all Germans. So, So anyways, Germans are awesome. So is sausage, so are noodles. Oh my gosh. Got to stop with the noodles, Joel. So we're talking about the low back. So this is a kind of a schematic of the low back with, of course, the muscle taken away, the skin taken away. And what we see here is our spine. Our spine is basically a stack of blocks, right? So we have bone on top of bone on top of bone, separated by this little rubber stopper here that's a disc. What holds all this together are these structures called ligaments. So ligaments is like the duct tape that holds everything together. It's the bolts that connect one bone to the next. So we need our ligaments. Then out of the spine, of course, you have your spinal cord back there, but then you have all these yellow nerves coming out. So if you had no nerves, you'd have no pain. So a lot of what we do when we're treating pain is isolating the nerve that hurts and then treating that nerve along with all these other structures that make up the spine. Because if I just treat your disc, if I just treat your facet, which is the joint that holds bone to bone, only so much of your pain is going to get better. And all those things break down when it comes to back pain. So let's go specifically to these different pain generators. So you've heard of degenerative disc disease, or I've got a disc that's bulging out, or my disc is what the doctor said it is. So the disc is basically a rubber stopper in between the bones. So you have bone, disc, bone. Inside the disc itself, it has this like gelatinous inside, okay? And then it has this kind of fibrin outside. The fibrin outside is very stiff. It's rubbery, it's hard. The inside is really gelatinous and soft, and it can dehydrate. But why the disc causes pain is you can get these little tears. It's called an annular tear. That means that fibrin circle, which holds that jelly in, the jelly is like a shock absorber in our body. You get a tear that goes through, then this jelly can kind of leak out. It's got a lot of inflammatory chemicals that then irritate the nerves, and you get a lot of kind of back pain. We're going to talk specifically about discogenic pain, or pain from the disc, here coming up in a little bit, and why that's important. This is a very specific treatment for this that's a little bit different from some of our other standard treatments that we'll talk about. The next thing we have to know about is called the facet joint. Has anybody ever heard of a facet? So a facet joint is basically you have two bones, two vertebrae, where those two bones come together, they form a joint. So that joint basically connects one bone to the next. So that joint is where two bones come together and they hinge on each other. So that's called a facet joint. But because there's movement in that joint for us to move around, those joints are constantly hinging, these things can break down and develop what's called arthritis. So arthritis is wear and tear, degeneration of those joints, which then cause their own specific pain pattern, which is different from that disc pain that we just showed earlier. And I'm going to go into each one of these one by one so you can go, oh, that's my pain, or that's my pain, or I have a combination of both. You can start to isolate what's causing your pain based on the anatomy and what the function of that area is. So next, one of the most important structures we have in our body, we have our ligaments. So a ligament is what connects bone to bone. So we have all these bones. All this white stuff here is the ligaments that are connecting all that bone together. It's the structure, if I take my thumb and I kind of start to crank on it, eventually it stops because my collateral ligament is telling my thumb, you can't move anymore, and it holds me in place. All over about my knee only goes so far, the ligament stops that movement, but it stabilizes those joints. The reason that our spine breaks down, we're going to talk about instability, is because when a ligament loosens, if these little joints or ligaments are loose, what happens to those bones? What are they going to do? They're going to start shifting and grinding. Year after year, it's shifting and grinding. Breaks down a little bit every month, every week, every year. It gets worse and worse because instability causes wear and tear. A good analogy would be if you're driving a car, right? And say one of your tires is slightly out of alignment, right? And it's wobbling because the bolts are loose. This tire is going to wear out a lot faster than this tire. This tire's stable, nothing's breaking down. This tire was wobbly. This tire's going to wear its threads a lot faster. Kind of makes sense. So instability leads to degeneration. So stability. Well, we need to know about stability as well because stability is how we treat. Stability is how we make you better. Stability comes from ligaments. These are the main guys that stabilize you. So they're going to just be working to stabilize joints no matter what you do. And then you have your joints and your capsule. So a capsule is actually like a ligament, but it's actually just a little round area that kind of goes around the joint. It holds a little fluid in there. That's the fluid inside the joint. But the capsules are essential also for movement of that facet joint that can break down. Then we have our muscles and our fascia. So muscles are kind of an active stabilizer. They're not there to really stabilize the micro motion, but they're there to help us move, stabilize, give us strength, be kind of a shock absorber. Has anybody heard of fascia? Like we heard about foam rolling or they're massaging out my fascia. Fascia is also a connective tissue that kind of surrounds all of our muscles and it anchors on the bone. So fascia, I'm finding now as I'm ultrasounding and doing all these injections, is often we have to treat your fascia as well. So these are all things that we can treat with some of the things that we'll be talking about. So part 2 in our talk now, we're going to go into why does the spine break down? Why am I not 25 the rest of my life? Why am I now feeling like a grandma, right? It's because the spine degenerates. We have to understand why things degenerate if we're going to regenerate or turn back the clock in those areas. So the common drivers of wear and tear in our body, this could be your spine, this could be your TMJ, this could be your knee, your hip. The body breaks down from overuse. So I've been working the same job for 50 years. I've been doing the same thing. I do it over and over again. Repetitive overuse breaks our body down. Probably one of the most common things is just I've been doing the same thing every day. My body's breaking down. A lot of us have trauma. When I was 25, I had this terrible car accident, or I fell off a horse, or I fell off a stair, and I had this terrible whiplash to my neck, and ever since then it's getting worse and worse. Injuries lead to the instability we talked about as well, which eventually wears you out. So any kind of fall or trauma, if we're talking in the clinic about any history of falls or trauma, years ago I didn't think it was serious, but I sprained my back, and since then you're right, it got better or it got worse. Lifestyle, so how we live our lives. Do we eat healthy? Do we exercise? Do we do proper nutrition? Are we sleeping 8 hours a night? All those things contribute to our body's ability to repair, but also contribute to our body breaking down. So we always talk about lifestyle. Genetics, I see this all the time. Okay, you're coming in, I don't want a back fusion, but my brother had it, my mom had it, 2 of my cousins had it, my Aunt Shirley had it. So it runs in families. Because our genetics, we pass along our genetics, which are our ligament stabilities, our muscle masses, our genetics, how we're prone to repair all those things. Hormones play a huge influence. If you look at the number 1 risk factor for degeneration in our bodies, it's going to be hormones. So guys from age 40 to 60, women from like around 50 when menopause takes place, we age so much faster because we're losing the hormone support. Things like estrogen, progesterone, testosterone, Those are what are called anabolic hormones. They keep us younger, they keep us healthy. When those things start to go down, incidence of chronic disease, including diabetes, cancers, spine pain, arthritis always goes up. So we'll talk about hormones a little bit in the future too, and how we can use hormones and all these things to maximize our outcomes with some of these things we'll talk about. So if we zoomed in on instability, so this is your back, right? You're driving along, somebody pulls out in front of you, 40 miles an hour, car accident, crash, your body does this. When it bends forward like that, that trauma rips all these things that we just learned what these are called. These are called ligaments, right? Your ligaments rip, your joint capsule rips, everything is basically, they call it a sprain. So you go to the lawyer always talks about instabilities as permanent, as non-permanent. Well, if any kind of a car accident, if you look at all the legal studies for car accidents, a lot of those car accidents lead to chronic disability, more degeneration, acceleration of the problem, because now you have an unstable segment. This never heals 100%. Sprains never heal all the way. You're always left with a little bit more instability. So year by year, this spine is going to break down a lot faster because those ligaments have been torn, they're loose, and now you're aging 3 times as fast. So the ligaments loosen, and then all that extra movement kind of starts to dehydrate and compress the disc. The disc starts to break down. And as those joints, the facet joints, continue to rub because they're unstable, they start to break down. That's called arthritis. Eventually, tons of grinding, eventually these little things called bone spurs start to grow. That can pinch your nerves that go down the body. So it's a continuous process of aging that gets accelerated with instability. This would be kind of the progression of a relatively normal low back. These are normal segments. Bone, disc, bone. Nice round disc here. Nice hole for the nerves to come out of. This segment here is slightly decreased. This would be called, I would say, moderate to more advanced degenerative disc disease. You can see that black space is much thinner than the space above. This is an example of degenerative disease plus instability. So this line, this bone has shifted forward. This one's here. This is called a grade 1 spondylolisthesis. And I said that today when I was dictating. The person's got a grade 1 spondylolisthesis in L5S1. So that's basically, this ligaments are loose. This is shifting forward. It's grinding down that disc. Years later, you're left with a spine like this. I saw another lady today with a spine like this. Advanced degeneration of the discs are breaking down, wear and tear. So this is kind of that chronic end stage of things are breaking down, my discs are gone, and I'm starting to get a lot of impingement. So if you looked at a schematic, here I am again. I get in a car accident, what happens? Boom, I sprain my back, the ligaments start to loosen, and I've got an unstable back. Eventually, if it continues to be unstable, my discs are going to herniate out. They're going to put pressure on this ligament back here. That's called the posterior longitudinal ligament. When that ligament gets pain, you get this dull back pain. Eventually, if that disc continues to go out, it's going to go left or right. The back pain gets a little bit better, but now you've got this leg pain because the disc is sitting on the nerve root. Then the pain goes down your leg. Now, years later, if these facet joints continue to grind and bind, then you start getting arthritis in your joints as well. So year by year, these things keep on breaking down. So the goal is to take you from this is young, this is after all the car accidents. The goal is to say, is there anything possible we can do to reverse this? 15 years ago, I'd say absolutely not. We just give you steroids, put you in pain meds, and then we go to the nursing home. But now we're finding there's a lot more things we can do, right? So part 3, where does the pain come from? You guys already know these answers because I've alluded to it as we've been going on where the pain generators are. So the pain is coming from the discs. It's called discogenic pain. We'll talk about what that is and kind of specific clues we see on your history of the diagnosis. It can come from our facet joints, these joints that hold us together. They can get arthritis. They can start grinding and breaking down. It can come from the nerve roots because if that disc herniates out, puts pressure on the nerve roots, that'd be these deep nerves in here, and the pain goes down your legs. It can come from peripheral nerves. So the peripheral nerves are these little guys. So see all these little yellow guys? They're coming out over the glute muscles, over the butt muscles. Those cause like back pain around the belt line. So it's, I got this achy low back. It's always right through here. Those are little peripheral nerves that are getting pinched, and those are really easy to treat. Finally, your muscles, your ligaments, your fascia, and your SI joints can all cause low back pain. So let's talk about discogenic, because there's a real new procedure that we're doing that is really specific to the disc itself. For this procedure to be successful, the pain has to be mostly discogenic. So this is going to relate to maybe 10-20% of you guys. The rest of you are going to, there's another procedure that we do, which is our general standard low back procedure. But this pressure here is going to be deep, achy pressure in the low back. Worse when you're sitting, how she's adjusting herself. So it's a little bit worse when you're sitting and bending. It gets a little bit better when you stand up and stretch. The reason it's worse when you're bending and sitting, because when you bend like that, what it does is those two spinal bones come together and it compresses and squeezes that disc. And that disc leaks a little bit out of that tear that I showed you, causes that centralized low back pain. That means pain in the low back that doesn't radiate. It does not usually go down the leg. When it's going down the leg, that means it's not just a disc tear, but it's herniating out, putting pressure on the nerve root. Those aren't the best candidates for this. We do something different for those patients. And these guys get a little bit better when they walk down, or if they kind of rest, lie back. A little bit better if they're walking around, those types of things. So why the disc hurts, we talked about that, is that this nice soft inside is leaking out through the tough outside. When it comes to that crack, it starts to irritate the spine and those nerve roots, and that's discogenic pain. It becomes very inflamed and very irritated because that disc is unhealthy and it's leaking. So now the next one, again, like I said, a lot of times there's multiple things going on at once. It's not always just facet or disc or nerve, it's always combined. But the other thing that can cause pain are these facet joints. This is different, whereas the disc is worse when you bend over. The facet joint, it's worse when I bend back. Because when I extend back, I'm basically jamming these joints together and I can bend and I can load them. Oh, that hits, oh, that's my pain. It's an extension pain that gets worse. Remember, discs are better moving forward. Facets are worse moving back. So we can kind of differentiate between the two of them. It's usually a pain right in the back. It usually doesn't radiate down the leg. Now, nerve pain, people have heard the term sciatica. Sciatica is just a specific nerve, the sciatic nerve, that usually radiates down the back of the leg, sometimes to the foot. It can be caused by a lot of things. It can be caused by disc herniating, putting pressure on the nerve, or it can be caused in the buttocks area from little muscles like the piriformis or some of the butt muscles. They pinch the nerve, causing that pain to go down the back of the leg. So there's different treatments for each one of those things that are happening. And then we do a lot of peripheral nerve work, whether it's carpal tunnel, TMJ work, headaches. This is an example of the low back. This is the buttocks. In pose there, this is the pelvis, the pelvic bones coming across. And so this is from a book that I used to teach doctors how to do these treatments. This shows you where all these little nerves go over the back. These are all tender spots that a lot of people have with these different nerve patterns, and these are very easy to treat to calm down those nerves. And we use a very neat solution called dextrose. And tonight I'm going to reveal how dextrose works because it's fascinating and a little bit nerdy. So look forward to that part of the talk coming up. The last thing is the fascia. So has anybody ever skinned a deer or an animal? You know that white stuff over the muscle, that's called fascia. Fascia is very innervated with nerve endings. So fascia can cause a lot of pain. It can entrap our nerves. This is kind of nerves popping through fascia. This is the body with fascia. See all these little nerves have to pop through the fascia to get to the skin? Those are all entrapment spots of nerves as well. So as you can see, the low back is very complex. There's so many pain generators. As doctors, we have the responsibility to figure out what it is so we can treat you right. But I'm just kind of showing you the complexity of it all. So how do we do this? First of all, we have a conversation with you. Tell me about how you're feeling. Have you had a car accident? How long have you had the pain? What types of things make your pain worse? Is it worse when you extend, when you flex, when you sit? What makes it better? And I always ask, what have you tried? Well, I've had 3 steroid shots, I've done nerve ablations, I've had a fusion, they've taken out my disc. So there's always a history of things that people have tried and have failed or haven't been as successful as they want. We always get some kind of imaging. We'll do a comprehensive examination where I'm pushing on things, I'm having you twist and bend, and I'm trying to figure out what's going on. We check your neurologic status. Are your nerves all working normal or something off, or your reflex is normal? We'll order some imaging. Often it's an x-ray. A lot of people come in to see me, they already have their MRIs or CT scans, so we'll kind of review that and kind of figure out what's going on. Sometimes we'll order a lab. So somebody's coming in and they're a hunter, they've been out in the woods all the time, now they're feeling back pain and fatigue. We're going to rule out Lyme's disease. We're going to maybe talk about what's happening with your thyroid, what's happening with your hormones. Because labs and abnormal kind of stuff happening on the inside can contribute to why the body's in chronic pain and breaking down. So this is what I call biotensegrity. It's kind of a new term that we use a lot in orthopedics. It says everything is connected, right? So this is basically the low back. This is the vertebrae. This is hard to see, but this is the spinal process in the back. All this stuff here is it looks like saran wrap wrapping up in the spine. This is all ligaments. But see, it's all connected. Like in anatomy charts, we showed there's a ligament there, there, and there. But in reality, all the ligaments blend together as one continuous structure. Then these ligaments, they blend and they turn into muscle. So it's one continuous pattern of tissue that everything is connected. There's no spot where it breaks. So we found that's not an isolated ligament, but everything blends. And so to me, when somebody has a herniated disc, all these different structures from the most superficial spinal process to the ligaments that kind of connect the facet joints to everything around the disc is one big stirrup. If you can start injecting and tightening up different parts of these structures, the whole thing tightens up and it pulls that disc back into alignment. So we often don't even have to go into the disc and treat the disc because by healing the structures tightens everything up, that pulls that disc back into alignment. Does that kind of make sense? When things are sloppy, everything pops out, you tighten it up, everything pulls back in. So what do we do for treatment? So we kind of know we've got the right diagnosis, we know why you're having your pain, we've got your history. Now we've got to present to you what are you going to do to make me better, because that's why you're coming to see us. So these are kind of our treatment options. The first thing is very conservative, like have you tried physical therapy? Do you have good posture? Have you maximized the things you can do to heal your own body? Are you sleeping good? Are you hydrated? Are you balancing your stress? We'll often send somebody to functional medicine. We've talked about functional medicine is looking at why the body's breaking down. Am I inflamed? What are my hormones doing? Then sometimes we recommend either medications or supplements based on people's needs, like have you tried magnesium? Do you take omega-3s? Are you on B12? Because some very simple supplements can have pretty good effects on people's pain and healing and inflammation in their bodies. Step 2 is, okay, I'm starting some basic stuff. Me as the doctor has made the right diagnosis. I know what's going on. I've got to put together a plan for you. Often we'll recommend some things maybe to the joints, the nerves, or epidurals. So I'm sure all of you guys dealing with chronic back pain have had epidurals. The question is, what type of epidural was it? Was it a steroid epidural or was it a new epidural, which we'll talk about, why we do the different types of epidurals. And we do try to avoid high-dose steroids or cortisone. Has anybody heard about the controversy with steroids and why we avoid them? Has anybody heard any of the talk on that? So I'll go into a little bit of detail on steroids because it's good to know the truth about them. If those are options out there, should you take them, should you not? Step 3 is, okay, we've got the right diagnosis, we've calmed down your pain, you're feeling a bit better, but now we've got to reverse the clock. We've got to try to heal the spine, we've got to regenerate those structures we talked about. The 2 options we have there are PRP and stem cell options. And we'll talk about those individually, what they are, how they work, and the mechanism behind those. So why do we avoid high-dose steroids? So did anybody know out there that using a steroid in the epidural space, according to the FDA, is off-label? So that means there's no safety and there's no efficacy data to say there's published reason to do a steroid epidural. The FDA doesn't even show it as a standard way to do this because it's off-label, it's not what it's indicated for, and what we're finding is that unfortunately it causes weakening and destroying of that tissue, whether it's the spine or the peripheral joint. And I've written tons of books on this, but if you look at the data in our research, and this is looking at joints and tendons, so this would be like your knees, your hips, your wrists, putting steroids into those structures causes cartilage damage. It accelerates the degeneration and accelerates the arthritis. So why in the world would you put that in your joint when your diagnosis is arthritis? It causes bone loss, so it weakens the bone tissue, increases the risk of fracture, bone breakdown, osteoporosis, stress fractures, and all those things. If you came in and you said, oh, I've got Achilles tendon problems, and I put a steroid shot in your Achilles tendon, increase the risk of rupture. That tendon is going to pop off the bone because it weakens the tissue and turns it into like a cottage cheese solution. You can get local reactions. Last year, I've been seeing this patient now for a while. He came in after going to his primary care doctor, and the primary care doctor says, oh, you have tennis elbow, let's inject some steroid into it. They gave him a standard steroid shot, like everybody's probably had 100 of them. He comes back and sees him had the steroid shot, and I looked at his elbow. The elbow was eaten away, the skin was atrophied, there was no muscle, it eroded the tissue and caused just a big old ulcer there. So it's basically like acid, it just erodes and it destroys the joint. Tendon rupture, local reactions, increased risk of infection. So again, it's not the first line, and there's a lot of reasons to not use that. This is a sports medicine article looking at putting steroids in the joint for knee arthritis. And what they said there is it caused irreversible damage with rapid decline in function. Wow. Who wants to put that in their joint, right? That's a terrible outcome. Increased pain, increased their symptoms related to arthritis. So it's 1980s. I mean, we're in 2026 now. It's definitely old medicine. What about steroids in the spine? It's similar findings in the spine. This is all the research years 2013 to 2021, 2009. This is all very current within the last 5 to 10 years. Increased risk of fracture, increased cartilage breakdown, increased bone density reduction and spinal fractures, increases that facet joint arthritis, which we're trying to calm down and reverse, causes systemic side effects, which means weight gain, diabetes, elevated blood sugars, increased risk of infections. All the things that we're really looking to avoid are happening with these steroids. So we've taken that away from my toolbox, but that doesn't matter because I've got a much better updated toolbox. And one of the main things I use to calm down people's pain right off the bat is dextrose. Dextrose, isn't that a sugar? Yes. Dextrose is a sugar, and so we use a dextrose solution. And I just recently added a few new slides there looking at the research on dextrose. So dextrose is a type of sugar. It's a carbohydrate. So what we're finding, I'll show you the reason why it stops the pain, but what we found is, one, it's safe. It's a non-steroid option for nerve blocks and epidurals. There's no toxicity. Reduces neurogenic inflammation. So neurogenic inflammation is just a fancy way to say I've got nerve pain or I've got pain that's related to inflammation in my body. it improves the nerve function. And so it basically resets these tender nerves, whether it's carpal tunnel, low back pain in the epidural space. And it helps with chronic spine pain using epidurals. So it causes a rapid relief of pain without having to use the steroids. What about dextrose in the joints? So dextrose has been studied in the joints to be safe with no chondrotoxicity. The reason that's just a medical word means cartilage damage. Remember that old study in 2015 from the Sports Medicine Journal show, it said causes breakdown of cartilage. It's chondrotoxic. Dextrose is not. But dextrose actually blocks inflammation. It improves the function of the cartilage, and it helps to tighten up and heal the ligaments. So this goes back to some stuff we did 20 years ago when I was in my fellowship program with something called prolotherapy. So prolotherapy uses concentrated dextrose to calm down pain and to start the process of repair in the body. So let's talk about what's in our toolboxes. So we call this the regenerative advantage. So when it comes to our standard regenerative procedures, we'll do joint injections, we'll do things using PRP, platelets, stem cells, different types of nerve blocks and epidurals using either the biologics or the dextrose we're talking about. So a standard procedure, if somebody's coming to see me with spine pain, neck pain, we have to address all those different structures that we learned in our anatomy session today. That the ligaments are the duct tape that holds all this stuff together. These are broad ligaments. If they're loose, things are unstable. So I've got to put platelets. Now what is a platelet, right? A plate is your body's natural healing cell. So if I cut my arm, what happens? It bleeds, right? But when it bleeds, the platelets come in, they start to put my skin back together. It starts to seal things up, it tightens things, it repairs things. So first off, I put platelets in all these little ligaments. This is all in the same day. Then I put platelets into these joints. These are the facet joints that hold segments together. I put platelets in there. All the muscle attachments, all the fascia, all the connections to the pelvis and the spine, all those get little plates. So it's like 40 different shots. It's very technical. But at the end of the day, the platelets then start reacting and healing your body. We'll also go in sometimes and we'll treat these nerves because nerves are a source of pain. So we can use those dextrose-based solutions over the nerves, reset your pain in a very healthy way without the toxicities of the steroids. So that's kind of an overview of the procedure, but what are the solutions that we use? So first off, we can use platelets. So a platelet is this kind of monster-looking cell. But you can see what happens is they have all these tentacles. So when one platelet gets in with another platelet, those tentacles cross and they cross-link. And that's going to the next one, to the next one. So billions of cells start to cross-link each other, pull things together. That's what causes these tendons, those ligaments to cross-link and tighten, is initially these monsters come together, they cross-link and they start to form new ligaments and new tissues. So where do we use the platelets? In the joints, facet joints in the low back, in our ligaments, because we can stabilize and tighten up those unstable ligaments we talked about, muscle and fascia, and now we're starting to put them into the disc as well in very select cases if it's that discogenic type pain. Then we have another solution. We've been using this for probably 15, 20 years. It's a platelet lysate. And basically this, see how clear this is? PRP is a little bit more cloudy. Sometimes it's red because it has a lot of platelets in it. This is perfectly clear because what I did with this solution is I took my platelets, put it in the freezer, and basically like a can of Coke in the freezer, it expands and it ruptures, right? The can ruptures, there's Coke everywhere. Well, this ruptures and it releases the insides of a platelet. Inside the platelet are growth factors. Growth factors that calm down pain, they heal and they regenerate, but they're not inflammatory. They don't stimulate pain and achiness. So I can take this platelet here and I can put this in the epidural space. This epidural has been studied to decrease pain for 2 years in the epidural space using a platelet epidural as opposed to the steroids or even the dextrose, even better than the dextrose studies. I can also use this in like chronic carpal tunnel with that nerve's damaged and I need the nerve to come back. So platelets in the lysate form, which is just the growth factors in that platelet, can actually heal, and we can put it right around the nerves. Now I'd say stem cells are probably getting the most press, the most research, the most data over the last probably 15 years because it's a more powerful cell even than the platelet. So the platelet was shaped a little bit differently. This is a very primitive cell. That means this stem cell can morph into cartilage, it can morph into bone, it can turn into nerves. It's a very primitive cell. It's a pluripotent. It means it's got the ability to form into whatever it comes in contact with. So in general, when we have injuries, stem cells are circulating through your body. They find an injury, they bind to that cartilage and they turn into cartilage. Or they're going through, they find that fracture, they bind to the fracture and they turn into bone. So stem cells can heal and they can repair just because it's almost like this is more like a seed. It can grow into something. The platelets, which we talked about before from the blood, is like a fertilizer. It causes the own tissue in your body to grow a little bit better on its own. So they work a little bit differently there. So the difference between the two cells, like I said, PRP is like a fertilizer. It initiates the growth of your own tissue to get a little bit healthier. When you have more advanced cases, then we'll use the stem cells to try to actually regenerate more cartilage where you have a lack of cartilage of your own. So it can grow things a little bit better that way. Dextrose, like we talked about before, it's not a steroid. It's very healthy. And I wanted to go into a little bit of talk right now. We're about half hour in. We're almost done on nerves and why nerves fire, why they cause a lot of pain, but how dextrose works around nerves. So has anybody ever had like a nerve entrapment like carpal tunnel or zinging down their leg? Any zinging, burning, fiery pain that's a nerve that's compressed and the nerve is screaming at us. Like it's painful, it hurts. And it's often doing it because it's compressed. If a nerve is compressed for a period of time, like if I put my finger on my carpal tunnel and keep pushing it, eventually I start getting zinging and pain into my fingers because that nerve is screaming, stop, stop, stop. Why is that nerve screaming stop? It's screaming stop because I'm putting pressure, I'm stopping the blood flow to that nerve, and I'm stopping the oxygen to that nerve. Right? What's in blood? Oxygen and nutrients. So with a lack of carbohydrate, with a lack of oxygen, nerves start to fire and say, that hurts. Take the compression off me. What happens too when a nerve gets compressed for too long, it starts to leak two inflammatory neuropeptides. This is a little sciencey, but very interesting. Those are called CGRP and substance P. So to dial that back again, if a nerve is compressed for too long, it starts to leak a bunch of junk. That junk is called substance P and CGRP. What do those things do though? CGRP, which is one of the things that a compressed nerve oozes, or a nerve that's hypersensitive or back pain it's going to leak the CGRP. It causes collagenylysis, that's the breakdown of collagen. So the cartilage breaks down. It causes calcification. So often I'll get an ultrasound of a tendon if there's calcium in the tendon. That's because the nerve is getting compressed, causing calcification of the tendon. It causes breakdown of bone. An osteoclast is a cell that breaks down bone. Increased stimulation of that nerve causes the bone to break down and fracture. It also, we said the other nerve that it increases is substance P. So substance P increases vasodilation. That means the area swells, it gets red, it gets hypersensitive, it's tender. So substance P is the increased tenderness, the swelling, the pressure. CGRP causes breakdown and degeneration of that. So we have to treat painful nerves. If I don't reverse the negative effects of a painful nerve, it's going to break down the body and cause chronic pain. Does that kind of make sense, simplifying it a little bit? So in general, nerves get compressed, they lose their carbohydrate and they lose their oxygen, they start to scream, they start to cause pain. We can put dextrose, which is glucose, around compressed nerves in the epidural space, blocks the negative effect of the CGRP, and starts the body to heal, allows the body to start to heal on its own. So where's the research on this? Well, how does that actually work? So here's a bunch of studies. So these two guys, back in, I think this was in the 90s, they started looking at nerves. And what they did to the nerves is they either starved them of oxygen or they starved them of carbohydrate. When they did those studies, what they found is this is just a graph showing nerve excitement. These nerves are excited, these nerves are calm. These nerves are excited because glycopenia means they've taken the sugar away from the nerves, they've taken the energy source away from the nerves. The nerves started to fire saying, ouch, it hurts, I need some carbohydrate, I need energy. When they restored glucose to the nerve, the pain stopped. Okay? So we're able to block pain using dextrose without having to use lidocaine or steroids, because what it does is it takes the energy source, which is lacking in that compressed nerve, and rehydrates, resets the nerve by giving it an energy source. What's fascinating about this study is when they took glucose, which is sugar, away from the nerve started to fire. Ouch, it hurts, I need some sugar. When they took oxygen away from the nerve started to fire, but not as intensely as it did with a lack of carbohydrate. When they took both glucose and oxygen away, it was a little bit worse, but almost the same as just glucose. So we don't inject oxygen around nerves, we inject glucose around the nerves because it's easy and it resets the nerve pain, makes people better like day one. It's a really easy and safe thing to do. This is a study that was done in 2016, repeated again in 2018, showing that dextrose, that very safe solution in the epidural space, is super safe, calms the pain without having to do those steroid shots. This is just an example of those spots that we'll treat with low back pain. I would say most of our patients come in to see us with low back pain. We'll reset these nerves first. This is the most superficial pain generator. Then we'll go to the deeper structures like the epidurals using dextrose. And then we'll go to the PRP and the stem cells to regenerate the spine. That's kind of how we work through those areas. So what I call the biotensegrity is what really differentiates, I think, our outcomes and why we used to be in a large database of probably 60, 70 clinics in the United States that were doing PRP to the spine. When we looked at all 60, 70 clinics, we had the number one outcome in spine. And it's because we don't just treat like one facet or one ligament. We treat 30 or 40 structures all at the same time. It's because there's multiple pain generators causing your pain. So we have to be complex. We have to be very retentive about this. We have to be type A and just aggressive on how we're treating and be very anal about it, because if we don't treat all those structures, the patient doesn't get better. So because we're so kind of nerding out, our outcomes are really good with those things. Again, we're targeting multiple structures. The last thing we want to go about is something we call the P3 protocol. So it's kind of this new, it's not new, it's kind of how I've decided to organize everything, because this becomes so complex. To get a person to feel better, have more energy, have more zest, run with their grandkids, and have less pain in their spine takes a lot of moving parts working together. It's not just one person, it's not just one treatment. So to do that, I'm going to talk about the P3 protocol in a second, but what I want to get to really quick, before I get to that P3 protocol, I want to talk about the disc. So remember when we said that the disc is very special, and that is a little bit different treatment, because for this treatment, it's a discogenic pain. There's a new procedure we're doing called a spine renew procedure, where we actually go into the disc itself and we inject stem cells and platelets into the disc. It's a very specific diagnosis, but the outcomes have been amazing as far as helping people avoid fusions and high-end surgeries that are costing, like we said, up to $150,000 to the healthcare system. So what is discogenic pain? We talked about this a little bit, but it's pain coming from the disc. Often this disc is going to dehydrate and wear if this center nucleus starts to herniate out, puts pressure on these nerves, and it's a lot of pain in the back. We said the pain gets worse when you bend forward. It's a little bit better when you're extending and unloading the disc. And so that is kind of your kind of back pain that's worse with sitting and bending. It doesn't go down the leg as much. When you have pain going down your leg, that means this entire disc is herniating out and putting pressure on that nerve root. And the pain tends to go down the leg. So the pain's worse when you're bending forward, a little bit better when you're walking, kind of loosening it out. There's certain findings on an MRI that we like to look at to make sure the person qualifies for this procedure. And what we're looking at is not a spine that's severely degenerated. Once we get to this, it's too far gone to put stuff in the disc. So when it looks like this, we put stuff in the facets, the ligaments, the muscle attachments. We still get great outcomes. But when people have this, grade 3 or less degenerative, that means you still have some space in your disc. You have an unhealthy disc, but it's not corroded all the way down. These discs here we can regenerate with bone marrow in those discs. What's the research showing? It's going to improve the function and pain. Very good, strong benefits there. It's safe when it's done correctly, and it's definitely decreasing people's need for surgery in those indications. It's called the spine renew procedure. So basically what we're doing is we're using the fluoroscopy machine. I can isolate the disc. I can go in, and then I test that disc with some contrast dye to see if there's a tear. If it makes this little electricity pattern, if there's some tears there, then I can go in, I can fill in those holes with platelets, and I've got a specific seal that I do. So this is kind of what the procedure looks like. I very precisely go in with the x-ray, get my needle into the middle of this disc. Once I'm in that disc, I'll inject the bone marrow, which is stem cells, combined with some of those platelets. So I've got seeds and fertilizer, my same mixture. I fill up that lousy, softening, dehydrating disc. The next thing I do is, okay, but I've got to seal this tear, or it's going to keep leaking out. Then I take what's called fibrin. So there's a very specific way I can take some of the blood out, and I take all of the fibrin out of the blood, which basically creates a scaffolding and a clot that can seal this up. So I pull the needle out just a little bit. I seal this with what's called a fibrin. It's called A2M, alpha-2 macroglobin, but it's a fibrin. Then I add what's called thrombin to it, and then the thrombin actually seals that. It turns it into a paste, and it just seals that hole. Then we have the patient lay for about a half hour, let that seal up. And then we do that standard procedure we talked about before. We hit the facets, the ligaments, the muscle attachments. So this is our standard procedure, is the ligaments, the muscle attachments, the disc. It's 90% of what we do every day. It's very, very successful. In that 10% of the patients where that disc is the problem and they meet certain criteria, then we'll add the stem cells and the plates to that disc, and then we'll seal that hole on the way out. And this, it's a little bit slower recovery because they've got to be, they can't lift much for the first few weeks. But when that starts to heal, it takes care of a lot of chronic pain that's been very disabling to people. We already talked about who's a strong candidate for it. The pain that's most in the back doesn't go down the leg. Worse when they flex forward. Only 1 to 2 levels are there, and they've tried conservative treatments without a lot of relief. The difference between the two, our standard procedure, which is that first one I talked about, where we put platelets or stem cells into the ligaments, the joints, the facets, the muscle attachments, great outcomes. Like I said, even when we were doing only this, we were top in the nation on our outcomes. Now, in the last 2 years, we've added the disc as an additional procedure for those specific patients that meet those requirements, and it's been very helpful as well. So the last thing we'll end with here, we'll probably take about 3 minutes just to go through this and have some questions, is it's called the P3 protocol. And so when patients walk into my office and I see these two twins and I see this twin versus that twin, it's easy which twin I'd rather treat. This guy is going to be inflamed. He's going to take a lot of work to decrease his inflammation, getting ready for healing. This dude's ready to heal. He's eating tons of carrots. He smells like a rabbit. He's ready to go. He's got abs, and we're jealous. So this guy, despite me being very envious, I'm going to be happy to see him because I know he's going to heal well. This guy takes some work. I've got to talk to him about nutrition. I've got to talk to him about lifestyle. I've got to check his hormones. But in the end, we can get him to heal, but we've got to fix some stuff on him. It's the same thing too, like if I come up from a line of farmers. So farmers plant things and they like to see things grow, but the farmer's not going to go plant in the soil. He needs to prepare the soil, get rid of the weeds, till it up, hydrate it, and this is going to grow some stuff. It's the same analogy when I'm trying to grow something in your joint or your spine and trying to repair you. Sometimes we have to do some prepare work. And so I call that the P3 protocol. The first P is I've got to prepare the soil. I've got to do some stuff in there to get you ready to heal. So some of those things are going to be to optimize your healing on the inside. That means checking some labs. What are their hormones doing? Are they eating healthy? Are they in good nutrition plans? We just launched a new program. It's called Reju for Life. And Reju for Life is basically anybody seeing us as a patient has access to a whole catalog of nutrition. There's about 2 or 3 cookbooks in there. It teaches you how to eat for pain, inflammation, longevity, healing, and weight loss. It's all in there. But we need to get people doing the basics first. That's preparing the soil. Sometimes they'll come in, we might do maybe a couple shots in the joint to clean up the bad inflammation using that dextrose to stop the bad pain. We might do some of those nerve blocks to get their nerve modulated so they can do more exercise. We'll start their physical therapy. And then we've got a date, okay, in 1 month we're going to plant. And plant is the procedure with the PRP or the stem cells. We're going to actually plant those biologics. Whether we're fertilizing it with the PRP or putting the seeds in there with the bone marrow or stem cells, that's the day of planting. We've already got the soil ready, they're prepared, they're eating healthy, they're sleeping good. And now we're going to get the body healed. So we plant those seeds. And then the proliferate is what happens afterwards. So it's not like we just one and done, see you later, hope you get better. We have you come back for follow-ups. We have you go back to PT in about a week to make sure your posture is good, you're moving right, that you're slowly getting back into activity as the body heals. We can allow you to do more things. We might go back in and we might treat those nerves again. Man, that pain's coming back a little bit. I've got a little bit of a hiccup in my recovery. Let's block the pain again. Let's get the dextrose in there. Or let's put a little more dextrose in that joint to help that nerve, that inflammation in the joint calm down a little bit. So that's the proliferation phase. But when we combine those P3s, we have great outcomes with our patients. So some of the take-home messages for us is, number one, we have to know what the pain generator is. If you go into somebody and they're not giving you a diagnosis of what your pain is or what the structure is causing your pain, you probably don't want them to give you treatments because they're not sure what they're treating. They're throwing darts at you. Number two, the right program of treatment requires that accurate diagnosis. So we want to make sure we do the right thing. Anytime that somebody's come to see me in an office visit, we have the steroid conversation. This is why we're avoiding it, because there's degeneration. It's not worth that short-term effect. And then we want to make sure that we're doing as much possible, combining as much as we can to maximize those outcomes so your body can heal better. So how it usually works is people come in, okay, I've got back pain, I don't really want anything, needles scare me, okay. There's different medications sometimes, there's different supplements, there's natural things we can do. We might plug you into functional medicine and have them take a look at what's happening with your hormones. If you've got comorbid anxiety, depression, and you just need some work, we have counselors that can help you work through some of those issues that always accompany chronic pain. Then our standard regenerative procedures are like the PRP and the stem cells. It's our bread and butter. We've been doing it for years. We have great outcomes. We're top of the nation on those things. Occasionally, we'll advance you to the advanced disc procedure. Again, if you meet the right criteria, you've got the right disc things going on, then sometimes we'll upgrade to that. We do have a surgeon that works with decompressions and fusions, but again, the cost of those, and sometimes you're like, you know what, that's the last thing I want is a fusion. And I don't love the concept of a fusion, so that's the last thing I would want, because when you get a fusion, you don't have to say if you've had one, and if you've had a fusion, I can still treat you. But a fusion, when you fuse two segments, the segments above and below always start to wear out again. So a couple years later, then you're fusing those areas. So if we can avoid it, that's great. So that is kind of everything in a nutshell when it comes to the spine, what we can do to help. Definitely want to open up to some questions.